Now, let me introduce nurse practitioners Sarah and Jessica from Community Care Pediatrics Latham, located at 6 Wellness Way off Route 9. Let's start with Sarah. Sarah is a board-certified pediatric nurse practitioner. She received her Bachelor of Science in Nursing from Russell Sage and Master's of Science in Child Health Nursing at State University of New York, Stony Brook. She has almost 20 years of nursing experience, having spent most of that time working in the neonatal ICU with premature and critically ill infants. Now, this is the next part that I really, really love. When providing care to patients, Sarah emphasizes the importance of communication, which, as we all know, as patients ourselves or parents or soon to be parents, it's critically important. As you'll be able to tell tonight, Sarah has a special interest in premature babies and children with special needs. Next up is Jessica. She is a certified pediatric nurse practitioner who graduated from Russell Sage College with a bachelor's in biology and nursing, and also received her master's in child health nursing from Stony Brook. Her career began as a registered nurse at Albany Med's neonatal intensive care unit. She worked at Bellevue in the special care nursery in addition to the NICU at Albany Med, so she also has extensive experience dealing with this population of infants and their parents. If their backgrounds sound similar, it's because they are. Jessica and Sarah not only worked together at Latham Peds, but they graduated from Russell Sage together and then also worked together at Albany Med. And now they are both excited to be here to speak on this topic and answer your questions. And we're happy to have them as our experts tonight. So I will now turn it over to Jessica and Sarah to begin.
Thank you. Appreciate that, Alexis.
Thank you.
We're here tonight to talk about the preterm and late preterm infant. Preterm infants account for about 10% of all births in the United States this year, or well, every year, not just this year. Late preterm infants are defined as infants who are between 34 weeks and 37 weeks gestation, whereas the regular preterm infants are those born before 34 weeks. That's sir.
Okay, can we have the next slide? Okay, can we jump ahead to the next one? So we're going to talk a little bit about things that put infants at risk for preterm birth. These can be maternal, fetal, or placental conditions, multiple gestations, sometimes inaccurate gestational age estimation where they think the baby was a little further along than they actually are, advanced maternal age, teen pregnancy, or chronic maternal health conditions, either pre-existing or something that occurred during the pregnancy. So small for gestational age infants or infants born less than the 5th percentile for their gestational age. This can be for different reasons. A common one is preeclampsia or high maternal blood pressure. Again, twins, triplets, because they have less room to grow. Sometimes infants may need special care because they're larger than we expect. There's difficulties at delivery. Something that can cause this, one of the more common things we see is being infant of diabetic mother that can cause baby to be born bigger than we would expect for their age. Sometimes these babies also tend to be pokey eaters and a little sleepy, so they need a little extra help getting started. Jaundice, which occurs when the babies are having a little trouble breaking down their red blood cells. It causes a yellow discoloration of the skin and eyes, and sometimes babies need a little extra care, including phototherapy lights and monitoring of their bilirubin levels before they can come home. Congenital heart disease, which may be diagnosed before baby is born or after baby is born, trisomy 21, or other genetic conditions diagnosed pre or postnatally.
Thermoregulation. This is something that is extremely important, especially for preterm babies. Preterm babies, they lack the body fat, they lack the maturity of their systems to be able to regulate their body temperature. They need that body fat, which they don't have, to help to increase their body temperature at all times. Complications from not being able to regulate your temperature can include things like hypoglycemia, respiratory instability, impaired growth, poor feeding habits. And all of these issues can increase the time that the baby needs to stay in the neonatal intensive care unit. So in the NICU, we tend to try to fix that with different interventions. First of all, we use warmers, radiant warmers, and we use isolettes that have covers over them to keep the temperature stable throughout the day. When the babies are first delivered, sometimes we wrap them in saran wrap, just the typical cling wrap you buy at the store, and that helps to maintain their body heat. We use hats and blankets to help them stay warm, and we promote kangaroo care, which is the same thing as skin to skin, to help raise their body temperatures as well. Next slide, please. In the late preterm infant, temperature regulation is also very important. They also have immature systems and can't regulate their temperatures as well as a regular term infant. So since they also need, since they also don't have as much body fat as the full term infants, like the preterm infants, and their skin is thinner, they have a hard time maintaining their temperature also. So complications from ongoing decreased temps can include low blood pressure, low blood sugars, and it can lead to respiratory distress, which can result in the use of oxygen for your baby. What else? Let me see. Sorry, checking my notes, folks. Decreased temperatures can also lead to difficulty in feeding, which is a big thing in the late preterm and the preterm infant. If they can't feed at regular intervals and intake enough calories, they're going to burn too many calories trying to maintain their heat. And that's why sometimes it does take a little bit longer for them to go home. We use the same kind of interventions for the late preterm infants as we do for the preterm infants. We use the saran wrap, we use the hats, we use the blankets, we use clothing for them. Sometimes if they require oxygen, we'll use a humidified oxygen to increase the temperature. And we use the same types of beds for them, isolettes, radiant warmers, or encouraging kangaroo care. And right here you can see on the left, that is a giraffe isolette. That's what Sarah and I have both used those. I think they're still in use today. It's been a little bit, but those are what we put the babies in when they're in the NICU. That maintains the temperature like in a whole environment. The picture on the right is a radiant warmer. That one, you put a temperature probe on the baby and heat comes from the top of it based on what the baby's body temperature is to bring the temperature up to what you've set it to.
The next thing we're going to cover is infant sleep. This is always a subject we get a lot of questions about, whether baby came early, has special needs, or was born full term. Infants don't always sleep on anybody's schedule. And especially those first few weeks can be really challenging. Most newborns need to sleep 14 to 17 hours a day. Premature infants may require even more sleep. In the NICU, if your baby needs a NICU stay, what we call cluster the care. So that means that we try to group feedings, diaper changes, medical interventions all together so that the baby can rest in between times and have the energy to feed or to snuggle with mom, and not be interrupting their sleep pattern, every hour or 2 hours if we need to do things. So we tend to try to allow for those periods of rest, and then that sets up a pattern to continue at home. For better or worse, baby is usually going to be on a schedule of eating about every 3 hours, and that's something that you'll practice with the NICU team before discharge. At home, you may find that your baby still needs to be woken up for feeds. Late preterm and preterm infants often need to be woken up for feeds because they're using more energy, like Jessica said, to stay warm. They're using more energy to eat. They tend to be a little sleepy, so they may not wake up on a schedule, and you might have to remind them. All infants need to follow the guidelines of safe sleep, or the ABCs of safe sleep. So that's alone, on their back, and in a crib or other contained sleep surface with a firm mattress. They can be swaddled in a light blanket with arms out, but absolutely no loose blankets, heavy blankets, stuffed animals, and that's the same for any baby. It's important to follow those guidelines, but especially with a premature infant. And no matter what grandma might tell you, hats are not safe for sleep. So we can dress baby in an extra layer of clothing, an extra onesie, but we don't want to put hats on for sleep time. Some other things that we can do to promote safe sleep are using a pacifier during sleep, putting a little fan on in the room, and making sure that the room is between 68 and 72 degrees, so not too cold and not too warm. And you want to make sure, again, that you don't co-sleep with baby. It's so easy to fall asleep, accidentally roll on the baby, even with best intentions. It's easy for those accidents to happen, unfortunately. And even when we're home in a recliner on the couch with baby and getting all snuggly and warm, it is important to stay alert. And if you're getting sleepy, place them in a safe sleep space, or hand them to another caregiver so you can get some rest. But it's important to be alert when you're holding the baby. The next thing we're going to cover is feeding and nutrition. So if you have ever had or currently have a baby in the NICU, this is one of the discharge goals that can take the longest and be frustrating. When babies are first born, oftentimes when they're born early, they need additional feeding support. This might include IV fluids, with some water, some sugar. If baby is more premature or has other special considerations, such as issues with their gastrointestinal system, they might need TPN, which is total parenteral nutrition. This provides protein and vitamins and fats, other things babies need to grow before they can take food through their mouth or through a feeding tube. Oftentimes, an NG tube can be placed in the nose. And there's a little picture of these little guys. A couple of them have an NG tube in their nose, and that allows for feedings to go through the tube. And then, as you see in one of the pictures, babies are practicing breastfeeding or bottle feeding. And when they get too tired, we can give the balance of the feed through the tube. And this helps them grow and gain while still practicing feeding. Once they're taking all their feeds by mouth for a period of time that would be determined by the NICU team, then they're usually ready to go home, as long as they're staying warm. In the hospital, you'll have lactation support and hopefully lots of teaching around this, but we're happy to continue that in the office as well, because feeding can be a big challenge. Typically, if your baby's had a NICU stay, they'll give you a discharge feeding plan, which will include the amount and the type of food that baby needs to grow and gain when they come home. So this is one of, other than staying warm, feeding is the main thing that babies will use their calories for. So we want to, again, balance that feeding practice with giving them time to rest and grow. Like we talked about, these babies may not always show feeding cues because they're sleepy, so we have to remind them to eat. Every 3 hours, they may be a little uncoordinated with their feeds because their nervous systems are still immature. So it's suck, swallow, breathe coordination, and they may choke a little bit. They may get ahead of themselves with feeds. So we need to pace those feedings and position them in certain ways so that they can eat safely. Many infants come home from the NICU on either high calorie formula or fortified breast milk. And if this is something your baby is going to need, the NICU team will help you prepare for that at home. They're going to give you a recipe for preparing that breast milk or formula, so it has a little extra calories than the formula that you would buy in the store or what breast milk provides. For different reasons, babies may need hypoallergenic formula. This could be milk protein intolerance or, again, digestive issues. And if that's the case, the NICU team will let you know that. And then we can continue to help you find the right amount, help you increase that as you go along, and make a change when that change is needed, usually around 4 months old. And again, we're happy to help with any questions because this is always a big one. So the next one we're covering is illness in newborns. Premature infants are at higher risk for viral and bacterial infections, complications from these infections. This is a frequent cause of needing emergency care and hospital readmission. Signs of illness can include fever, difficulty breathing, and poor feeding. So ways you can prevent infections are immunizing adult caregivers, frequent hand washing at home, limiting visitors, especially in people who have had any fever, respiratory, or gastrointestinal symptoms, that's vomiting, diarrhea in the last 48 hours. And this is a hard one for a lot of people because babies are very cute, but no kissing baby on the head, face, or hands. If they really have to, they can kiss those little baby feet, but we don't even like that. Sometimes, as you probably know, you can be contagious for days before you even have symptoms with cold symptoms, gastrointestinal bugs, or even things like if somebody has herpes, cold sores, you may not have a spot when you go visit baby, but one may pop out tomorrow and you would never want to expose baby to something contagious like that. When baby comes home too, for the first few weeks, it's really best to stay home, avoid those crowded locations, grocery stores, Target. It's, sometimes you feel a little stuck in the house, but with premature infants, small for gestational age infants, and infants with other health conditions, it's really important to keep them safe from germs as much as we can. Some parents will even put no touch signs to keep them away from curious people, especially if you have multiples, everybody wants to see them. But we don't want everybody touching babies. And in our office, we have separate sick and well waiting rooms. So our kids with colds and other illnesses go in a separate space. So try to minimize that contact and exposure while you're waiting to see us.
I'd like to just add as well that especially during this time of year, as we're entering into RSV season and flu season, and we've seen an uptick in COVID recently, that it's even more important to make sure that the people who are around your baby are feeling healthy and well. And it's always okay as a parent to put that boundary up that nobody can visit unless they fit your qualifications, basically, which is that there's, they're not sniffling and they feel great and things like that. And if they don't, FaceTime is wonderful, or they can just wait for another day.
Yep, you're the gatekeeper. That's okay.
That's right. Yep. So follow-up care. With preterm and late preterm babies, we tend to follow them a little bit more closely, especially in the first couple of months. Usually within 1 to 2 days after you're discharged from the NICU or from the regular term nursery, if your baby was a late preterm baby, we'll see you in the office. We'll do your first weight check. We'll check out the baby. We'll see what the bilirubin looks like. And we'll decide when the baby needs further follow-up. Sometimes that's in 2 days. Sometimes that's the next day. It always depends. Every baby's different, so every baby's plan of care is going to be very different. We start with well child visits at 1 month of age, and then we follow the AAP guideline schedule for that, where we see them again 1 month, then 2 months, then 4, 6, 9, 12, etc. Immunizations are always given according to the chronologic age. So even if your baby is 4 weeks early, we don't necessarily take that into account when it comes to the immunizations. That's still been studied and still been proven safe for them to have the regular immunizations on the immunization schedule. We'll also help coordinate your specialist visits. We have case management in our office, and they are happy to work with you to help you keep your appointments straight, and to help make sure we get all the notes for your appointments so that we can be your medical home. Every preterm, excuse me, every preterm infant or late preterm infant that spends time in the NICU will automatically get a referral to developmental peds, usually around 6 to 9 months of age. Infants who are born preterm or late preterm are at an increased risk of having delayed development. This can include cognitive things, this can include motor delays, this can include sensory or behavioral issues, and some of these can present a lot earlier than others. For example, if your child is not sitting or walking within the expected time frame, then we may know a motor delay. At each well child check, your provider will be assessing your infant's milestones and neurodevelopment, and taking a history from you to see what you're seeing also at home to make sure we're on track. Based on the neurodevelopmental assessment, that's when the provider will determine whether or not a developmental evaluation is needed further with our developmental pediatrics team, which happens to be right next door to us in the same building. So very easy. Late preterm infants, though, if they did not require NICU support, they'll just be monitored in our office. And we usually monitor them a little bit more closely. And we kind of see where they're at with each well child check. And if we have any concerns with them at all, maybe we'll refer them for developmental, or maybe we have different things to do. Like if it's a motor delay, we may refer them for physical therapy. So something like that. All right. Thank you very much. We appreciate you tuning in tonight. If you have
We
any
have a number of
questions,
questions.
let us
We
know.
do.
Oh, good, great.
How long does it take typically for a late preterm infant to stabilize their ability to regulate body temperature?
So it is not a one size fits all for that. Late pretermers generally do that, or are able to do that a lot quicker than more preterm infants. However, they generally don't require the same types of, like the same level of intervention that a preterm infant would. So a late preterm infant, say who's 34 or 35 weeks, may be able to go home with the parents right on schedule as if they didn't realize they were preterm. And then other times you may have a 35 weeker who really they're just more immature, and they just need that extra support in order to make sure they're gaining weight appropriately, and they may need a little extra time.
And sometimes birth weight can be a factor in that too. An
Mhm.
average or large for gestational age baby just has more fat. It's a little easier to stay warm. Smaller babies, or again, multiples, may just be a little smaller, and that may take a little bit longer.
Okay, let's shift to a sleep question. If my baby seems too sleepy to eat, what are some tricks to help keep them awake during a feed?
So unbuttoning or removing a layer of clothing. You don't want to make them too cold, but so they're not so sleepy and snuggly, unswaddling. Sometimes even taking like a warm washcloth and rubbing their face or their feet with it, putting lights on, and just allowing a few minutes for them to wake up before you start feed, just kind of talking or singing, letting them know it's time, but kind of bothering them a little bit, hate to say, but making them a little less comfortable. That can be helpful.
Okay, give me one sec. I saw another feeding one. I'm sorry, sleeping one. How do preterm babies' sleep patterns compare to full-term babies?
So preterm babies, I would say sleep well, first of all, they sleep more. And they usually, when they've come from the NICU, are on a schedule, which regular babies are not ever on a schedule, not right in the beginning anyway. So your preterm babies they're almost trained, because in the NICU and in a special care nursery, we bother them every 3 hours. And they kind of get used to that. So by the time they go home, they're on that schedule. So they will eat, they have their diaper changed, do all the things, and then they will sleep right in between feeds pretty soundly, until they start getting a little bit older. Whereas regular term babies may just be all over the place with their sleep. They may be sleeping for an hour and then they want to eat, and then they may be sleeping again, but then they may be awake for 2 hours, but then they may be sleeping again. So it's kind of, it's all over the place.
Okay, let's go back to feeding for a minute. What are some signs that a baby is struggling with feeding?
One of the things I would say would be the time it takes them to complete a feed. And if you've had a NICU experience, know that the goal is generally to be taking a breast or bottle feed within about 30 minutes and getting that in. If we're extending beyond that time, then we cut into that sleep and rest time that we've been talking about. That's so important. So if you have a baby that's taking an hour to finish a feed, they finally fall asleep, and then you've got to wake them up again in 2 hours to change the diaper and getting going. They're really not getting that rest. Another thing would be uncoordinated feeds, so choking and gagging, and that can happen a little bit with any baby. Just like a little sputtering, a little coughing. Sometimes that can happen as they're uncoordinated, but they're frequently choking. You're frequently having to interrupt feeds to sit them up, clear the airway. Then that can be a sign that they're not quite ready either.
How can families politely set boundaries with visitors to help protect their baby from getting sick? Do you have any tips on that?
Um, for me personally, I wouldn't worry about the politeness. I want a mom and a dad, or a mom and a mom, or a dad and a dad to feel absolutely comfortable saying, this is our baby, and we love this baby, and we love you. So this is what we're going to do. Um, if somebody reacts poorly to that, knowing that you're trying to protect your baby, that's on them. That's not really on you. So, although the conversations at first can seem difficult, when you have them in really a loving way and make it about protecting the baby and loving the baby the best that we all can, that usually helps a little bit.
Okay. Are there any resources or programs parents should know about for extra support?
There's a lot of lactation support in the community. We have several lactation consultants. I don't have their contact information on me right this second, but we've used several lactation consultants in the area. There's lots of kid things, like there's a kids care PT. There's OT for kids. There's developmental peds. There's so many pediatric specialists in the area if your child needs that. There's plenty out there, and if you need something, we can figure out a way to get it for you.
Another thing I would mention along that line is an early intervention program, which goes county by county. So again, going back to if there's any developmental concerns identified, then that's something that we can refer to as your medical home, your primary care provider, or developmental may suggest that as well. But that's a resource out there. And also Capital District Moms, just for social support. Once you're out of that, first immediate discharge home where we maybe want to keep baby away from germs when you're ready to venture out. Capital District Moms has lots of regional groups just of a lot of new moms, just kind of get out for some social support, because it can be a little isolating having a little one at home. So those are good things.
Okay, I'm gonna give it a minute or two for the rest of the questions. Maybe I'll just pose a question to the team as we wait for more to come in. Obviously, if a baby ends up in the NICU, it's stressful and overwhelming. Is there anything from your perspective as, parents or pediatricians that, to prepare somebody for that, or things to know, anything that you would like to inform those on the call about?
Um, Do you want to take that one, Sarah?
Oh gosh, I think it's hard because, in the NICU, again, there's a wide range, and I think some parents, for better or worse, may know that their baby is going to come early. There may be an underlying medical condition, and they may know that preterm birth is likely and have a little time to prepare for that emotionally. Sometimes things happen very emergently, and we have no time to prepare that this is going to happen. And as we mentioned a little bit, you may have a late preterm baby that's in the NICU for 4 days. You may have a baby that's born at 24 weeks gestation in the NICU for several months. So that experience is going to vary. But I think, anytime you're dealing with the baby, babies have their own agenda. But it's always important to advocate for your baby, ask questions if you don't understand something. Something that, ask questions of the medical team. That's what they're there for. And have patience. There can be, small wins and setbacks, and it can be a little frustrating, but just be patient. And again, just the medical team is there to ask questions as you go along. If you don't understand something, they're your best resource.
Okay, that's great. One more question that came in. Actually, let me just make sure that's the case. Are preterm births more common than they seem, or are they predictable?
I wouldn't say they're predictable, because there's so many factors that go into why a child may be born preterm. Whether it has something to do with the mom or something to do with the baby. There's too many factors to say that it's predictable. I would say I don't know, what am I trying to say? Uh, it's not, it's been steady, I would say, for the last about 10 years. We've had pretty much the same numbers. The March of Dimes works a lot with research on that. And we're still trying to figure out, really, is there one true cause versus just a complexity and a spectrum of different conditions that could contribute to it. So
There's one more question. That was not the last question. Do late preterm babies usually, quote unquote, catch up with full term babies in terms of growth and milestones?
Yes, usually by about 2 years of age. So as we're doing our routine developmental assessments, like Jessica said, our 1 month, 2 month, 4 months, there's certain things we're looking for babies to do. And to a point, we account for the prematurity. But by 2 years old, usually our late preterm babies, or babies who have not had a lot of complications during their NICU stay, would be catching up with their peers that were born full term. Well, thank you so much for coming. We hope that everybody has a safe and healthy completion of their pregnancy, or is enjoying their newborn, if that's why you're tuning in. But thank you for coming tonight.
we appreciate it. Thank you.